all. Now we will go to the other session, long gap esophageal atresia. There is a panel discussion. Moderator is Dr. Pavai.
Thank you, Dr. Karpanan. Good afternoon. Is Dr. Senthil there?
Yes, madam.
Okay, Senthil. So shall we start?
So the participants will be Dr. Senthilnathan, Dr. Sen, Dr. Rajendra Saoji. All of you are available?
I don't think Saoji has joined yet. Anyhow, we'll start.
Yes, okay.
I have called him. I tried to message him, madam. We'll get the message to him.
Yeah, that's okay. He can
Dr.
join.
Sen is available?
Can I start, Ramesh?
Yes, Sudipta sir is there.
Yeah, Sudipta sir is with me.
Thank you. Thank you.
Thank you. So this program is for 45 minutes and the basics will be covered by Dr. Senthilnathan, the surgical management and experience sharing by Dr. Sudipta Sen, perioperative care by Dr. Rajendra Saoji, and recent advances by Dr. Dariusz from Poland. Long gap, Dr. Senthil, long gap esophageal atresia, how will you diagnose and what is your protocol? Perioperative steps taken to manage the long gap esophageal atresia. And pre-op investigations, a patient with esophagostomy and gastrostomy before replacement. On to you, Senthil. Senthil? Hello? Senthil, are you there?
Yeah. Good afternoon, madam.
Yeah.
Yes. My screen visible?
Yes, your screen is visible.
Shall I start?
Yes, please. Oh, you want to share your screen? I'm sharing your screen. Senthil?
Yeah.
Yeah. Can you see the screen?
Ma'am, we are not able to see the screen, ma'am.
No, somebody has paused it. Paused it.
With the basics.
My screen.
Yes.
Resume share. Okay. Right? Now can you see it? I think somebody is not allowing me. They have to allow.
See my screen.
Madam, Dr. Pavai madam is very much audible. Senthilnathan sir is not audible and the screen does not move.
No, I am sharing the screen, Dr. Adiman. You have to.
But anyhow, to the participants, Senthilnathan does not seem to talk or listen.
Dr. Pavai, your screen is moving. Can you go to the first slide, please?
Yes, yeah.
No, which is your first slide, title slide?
Long gap esophageal atresia, TEF.
No, there was one slide before that.
Before that is just the questions, Ramesh.
Yeah, okay. So now it is moving. Yeah, I can see it. Yeah, it's working. Yeah, next slide. Yeah. I think there's some problem with the Dr. Senthilnathan's net connectivity.
Dr. Senthilnathan, we are not able to see or he is not able to hear us at all. Please call him by phone and inquire.
He's just across.
Can I move on?
Senthil, you can join with the phone because I'm doing the screen sharing.
Okay, I'll ask him to join from Rohit's phone, no issue.
Yeah. Ask him to do it from his phone.
Yes, sir.
Sir,
recording in progress.
We cannot hear you.
Yeah, am I audible?
Yes, Senthil.
Yeah, sorry for the hiccups. Before I go into the topic, a few slides on the development. Esophagus is a foregut beginning. On the ventral aspect of the foregut is the
Sorry, we are not able to see your slides. Please share your screen. Put share. Share screen.
You cannot see. Dr. Adiman, you cannot see the screen?
I can see Dr. Senthilnathan. I am not able to see his slides.
I can see the screen, sir. Long gap esophageal atresia TF.
Yeah.
That is not the one which is putting. That is Dr. Pavai madam's
This is
slide.
Dr. Pavai's screen.
Dr. Adiman, I am doing all the screen sharing for all the participants.
And then please take up the slide which he is talking about.
This is the slide he's going to talk about.
Okay. Let him continue, sir.
Yeah. Yes, and then you can carry on.
Yeah, the long gap esophageal atresia, tracheoesophageal fistula. To begin with the embryology, foregut is where the esophagus begins. On the ventral aspect of the foregut, a laryngotracheal groove develops at 23 days. This groove elongates, so too the esophagus also elongates. Then mesenchymal ingrowth separates trachea from esophagus. If this mesenchymal ingrowth separation doesn't occur properly, then tracheoesophageal fistula occurs. So the problems of tracheoesophageal fistula is due to the failure of the mesodermal ingrowth to separate the ventral trachea and the esophagus. All the problems of the common variety of esophageal atresia, tracheoesophageal fistula, upper blind, lower, as well as the pure atresia, all that can be explained by this problem of failure of mesodermal septation that has to take place around that time. And finally, the mesoderm goes away because of apoptosis. Now, how to diagnose antenatally esophageal atresia with tracheoesophageal fistula? Next slide. Ultrasonogram is the commonest modality which we do. Polyhydramnios is the commonest feature which we look at. Polyhydramnios is defined as an amniotic fluid index 18 centimeter or a deepest vertical pocket of greater than 8 centimeter. Usually, amniotic fluid index is measured in 4 quadrants. So you have to measure each quadrant, and the depth of each vertical pocket is summed up. So you have more than 2 pockets or 3 pockets, say 8 centimeter each. The total depth sum exceeds 18. Up to 18 is normal. That is a very conclusive proof for polyhydramnios. The associated findings which also clinch the polyhydramnios, which will helpful in the diagnosis of esophageal atresia or tracheoesophageal fistula, because the fluid is not swallowed by the baby. That is absent fetal stomach. It is defined as a non-visualization of fetal stomach on the scan after a prolonged observation, say greater than 30 minutes, or a small fetal stomach defined as presence of a fetal stomach of a reduced size according to the published fetal nomograms or upon subjective assessment. The third is the pouch sign, defined as a visualization of fluid-filled, blind-ending esophagus during fetal swallowing. Pure esophageal atresia are diagnosed more frequently than EA with EF. Next slide. Next slide. Madam, can I have the next slide? Yeah. So, as in the morning, the speaker, Dr. Rajkumar from Australia, was talking about fetal MRI. Though fetal MRI is not done as a routine procedure here, but fetal MRI is highly specific in the diagnosis of esophageal atresia. And this picture of sagittal view, we can see the arrow mark points to the esophagus, the T2 weighted image. And after that, the esophagus is not visualized. So that itself is a definitive mode to diagnose antenatally esophageal atresia. Next slide. Now, what is the definition? For many people, a surgeon who is beginning to operate, even a 1.5 centimeter gap, maybe a long gap esophageal atresia. But the fact is, well laid down definitions are there. So if you have a 5 centimeter gap between the upper and lower pouch, that is the sign for a long gap esophageal atresia. Each vertebral body is about 1.1 to 1.25 centimeters in length. So if you have 4 vertebral body gap, then it suggests you are dealing with the long gap esophageal atresia. Next slide. So in this X-ray, very clearly you can see the coiled ingitube, 12 French size we must use. At the level of T2, that the coiling stops. Usually it should come to around T4 for a normal gap. So this is a nice X-ray if taken with a digital X-ray with a good intensity. We can diagnose preoperatively a long gap esophageal atresia. Next. So this is a conventional or a common variety which we deal, where the coiling of the tube you can see coming down up to the T4 level. So this is a normal gap esophageal atresia with brachioesophageal fistula. Next. Pure atresia is very obvious, gasless abdomen, but invariably pure atresia, it will be a long gap. We are not able to do a primary procedure for these cases. Next. Next slide. So immediately in the newborn period, what to do for a long gap? Usually, if we have a good assessment based on this, we go about with a thoracotomy as usual, ligate the fistula with the communication in case if it is a OA or TEF. If it is a pure atresia, we can straight away go if a diagnosis is made with upper pharyngostomy or esophagostomy. You can dissect the upper esophagus gently, bring the fundus out to the skin level, either at the supraclavicular level or at the infraclavicular level. Then for feeding purpose, if you have ligated the fistula, we plan the feeding gastrostomy. One thing which has really changed the outcome of these children, say a decade back from now, is this tube called the Mickey's button gastrostomy. Previously, we used to put a Foley catheter, Malicot, all that, which will never work. It will get blocked. The mother also, after discharge, will have a lot of reservations in carrying a big tail on the abdomen. And in those days, many cases won't turn up for definitive surgery. Once in the last 3 years, we have started using this Mickey gastrostomy tube. The compliance from the parent side is very good. Feeding can be started on the 3rd post-operative day. The weight gain and all other things do very well after the introduction of this method of a Mickey button gastrostomy tube. Next. Next slide. Now, shall I proceed now what to do these cases, or shall I have to hold on? Madam.
I think you should finish your talk, Senthil, so that way, yeah.
Okay. So these children are do very well on feeding gastrostomy. Weight gain is good. If otherwise no incidents or episodes of hypoxia during the perinatal period, their growth, development, physical, mental, everything is all right. And when to take up for the definitive surgery? No. See, 1 year is what the recommended age. But I personally feel you can take it in a delayed manner, say 18 months. Even textbook of neonatal surgery recommends 18 months, maybe the ideal one, even in the Western literature, as far the textbook is concerned. Even our own experience, I feel, if you take it around 18 months for these cases, the chances of them doing very well is good. The important preoperative point which I like to make is before surgery, 4 to 6 weeks prior, I start them on metoprolol. It is a cardio-selective beta blocker, and it has got a very important role in stabilizing the heart during the perioperative and the post-operative period where we encounter a lot of intensive care problems. So 6 weeks prior to that, metoprolol can be started appropriate to the weight of the child. After that, if any need arises, we can back up the child preoperatively with the FFP or any vitamin, multivitamin infusions, get the informed consent, get your intensive care ready for a prolonged ventilation. Then we have to take up this case for surgery. The surgery which we do in our unit is gastric transposition. Of course, Professor Velmurugan is doing gastric tube also, but I have, along with Bharti time itself, we have been doing this gastric transposition. It's a major procedure in the sense the stomach has to be mobilized without damaging the two important blood vessels, namely the gastroduodenal and the right gastroepiploic artery. Based on these two vessels only, the entire stomach blood supply will hang. And by dividing all other structures, short gastric, gastric, left gastroepiploic, adequate mobilization of stomach will be obtained. Once you mobilize the stomach, how good is your mobilization? What is the index? So if you see pylorus, the pylorus must reach the esophageal hiatus. We choose only the shortest route. The shortest route is the natural esophageal hiatus. Though there may be additions, but a gentle blind dissection from the neck as well as from the abdomen, we will get a good passage in the natural hiatus. And the pyloric end must reach the esophageal hiatus. Regularly for my cases in our unit, we do a pyloroplasty. Though there are literature which says there is no need, but we have bitten in the first cases by the prolonged gastric dilatation. Pyloroplasty will avoid that. So we do a pyloroplasty at this level. Then after tunneling, very gently, with always taking care, the important structure bronchus. The main bronchus is anterior to it, and the tunnel is made wider, first with the roller gauze, gently well lubricated roller gauze, metallic, we get an adequate space to tunnel this stomach. Next slide, madam. Yeah, so now we have created the tunnel. You can see the left lobe of the liver, the tunnel is ready to take the stomach which has been mobilized based on the right gastroduodenal, right gastroepiploic pedicles. You can see the pancreas here. Next slide. So by careful tunneling, we reach the neck. If you have a very good team, the neck portion can be dissected very well by your assistants. So I am fortunate to have good assistants who have been working with me who will dissect the neck. So by the time the abdominal procedure is done, the neck must be ready. Because these are all major procedures which will require a long time of surgery. And prolonged surgery, surgical trauma, post-operative care, all that depends on the operating time. This is my take on that. So if the neck is ready and the esophagus has been dissected, one important point here in the dissection is the recurrent laryngeal nerve in the neck. So any cord-like structure which is hugging the esophagus, you should not divide, you should take care. You may take care of the internal jugular, you may take care of the carotids, but the recurrent laryngeal nerve may get missed because it is stuck to the esophagus in the tracheoesophageal groove. So we have to take a lot of care in identifying the RLN nerve and preserving. And here you can see the upper esophagus mobilized well, and the gastric fundus has reached. The native esophagus, that portion, the small stub must be excised. You should never try to make anastomosis with the native esophagus and the cervical esophagus. You have to choose a good area on the fundus, and this is the stay. This is the fundic area. This will be the site of the anastomosis. Next. Next slide, madam. Next slide.
Yeah, one second.
Yeah. So this slide shows the anastomosis done over between the esophagus and the fundus. To prevent any retraction, a seromuscular stitch on the prevertebral fascia and the posterior wall of the fundus can be taken so that the anastomosis is without tension. Now, at this point, I like to put one more our experience. What we do, we put two nasogastric tubes. One nasogastric tube will enter the stomach across the pyloric antrum into the duodenum. We can use for feeding purpose. The second tube, you will leave it in the body of the stomach, right? The patient neck wound is closed with the drain, the abdominal wound is closed, and post-operative care becomes now very important. This is the time when children are on the ventilator. Even the literature, if you observe, minimum 4 days of ventilation will be required for cases because the stomach starts dilating. So every hour you have to decompress the stomach. That's why you have kept two tubes, one in the stomach, and that regularly decompression must be done by the nasogastric aspiration. And the stomach dilatation will start only after 48 hours. And how to recognize that is the increase in the heart rate. That is the time when the heart rate gallops from 110, 120 to 140. To prevent that cardiac embarrassment only, to stabilize the heart, metoprolol will go a long way. Not many believe, but I strongly believe in that in a center like ours, where we have to keep the heart rate down. In the cases where we have not lost due to the graft loss and all, but the tachycardia is so severe, they will run for ventricular tachycardia, VFib, and a cardiac arrest. So you have to manage 4 days of very good ventilation, and IV fluids we can give 80% of the volume. If you're going to give like the standard 100 ml per kg like that, it will increase the edema. So the intensivist feel you can reduce the fluids to 80 ml per kg, 70 ml, depending on the urine volume, depending on the hemodynamics of blood pressure, pulse, and that will reduce the serosal edema and the gastric dilatation at the mediastinum. Once the 4 days is over, the heart rate is stable, weaning process can start. Next slide, madam. So this is the boy we did about a couple of years back before the first lockdown. He has grown well, you can see in his different attire. This the emergency duty surgeon brought the esophagus on the left side of the neck. But it's preferable you bring it on the right because the right is the straight course. Next slide. You can click this, madam. Double click.
Not working.
Double click.
Not working.
Not working. Okay. This is the today morning. Yes, mother has been with us. She sent this video and is doing very well, gained weight, is ready to go to preschooling. So gastric transposition is the thing we do it for long gap atresia or pure esophageal atresia. And the take home points is one good end esophagostomy, Mickey button gastrostomy, entire stomach is transposed, taking care of the right gastroduodenal gastroepiploic vessels, tunneling in the original root of the esophagus. Recurrent laryngeal nodes should be taken care in the neck, and post-operative for 4 days. That's all, madam, from my side.
Thank you, Senthil.
Yeah.
I request Dr. Sudipta to share his experience.
Thank you, Dr. Pavai. We're talking about long gap esophageal atresia.
Yeah.
Now, as far as I'm concerned, rather than taking vertebral levels, that is of course important academically, the long gap esophageal atresia in my mind, non-feasibility or failure of primary repair. Now there are two groups of patients, pure esophageal atresia who are almost always long gap, and the esophageal atresia with TEF which occasionally has a long gap between the two ends. Now, in pure esophageal atresia, we have this situation, and you can manage them either. There are two philosophies: without esophagostomy, just a gastrostomy, and with esophagostomy and gastrostomy. Now, what Dr. Senthil said was the traditional, most of us manage these patients with esophagostomy and a gastrostomy. The child learns to feed, sham feeds, which is quite important. The child grows well. And though I have drawn a traditional Foley catheter, now the Mickey catheter is there and it's much more convenient. And the child can grow quite fat because the children are fed not as much as child wants us, but as much as the mother wants. So the one problem with them is we get quite fat children when they come for reconstruction. Now, other method which is gaining popularity nowadays without esophagostomy. Here, we hope that the feeding will push this up and the saliva will push this down. And like two lovers in a Hindi movie, they're inching towards each other as time goes on. But the disadvantage is they need expert care in the ward. Otherwise, the child might drown in his own saliva and constant suctioning. Mother has to learn suctioning and the prolonged stay in the ward with increasing costs and occasionally at the cost of some episode with resulting in mental retardation and all that. So it's a tricky thing to do, but some patients are opting for this kind of management, and we hope that we'll ultimately be able to bridge the gap using the native esophagus. But it doesn't occur overnight. It takes several months for these things to come close together, if at all. It may not come out also, but sometimes it does come. And today we have a guest speaker who will talk us about hastening this process by using the thoracoscopic suturing technique, which I'm very interested to listen to. Now, on the other hand, in esophageal atresia with TEF, the traditional one, we have to do a thoracotomy to control this fistula. And it is a very rare surgeon who will not attempt to anastomose when after having opened the chest and got the lower pouch and asked the anesthetist to push and all that, and they will anastomose these two, but it may fail. That's what we are talking about. And if it fails, we'll end up with a bad chest, a sick child with bad lungs, and a bad esophagus sitting in a bad chest with multiple strictures, leakage, empyema, recurrent fistula, and all that. So that's that sort of scenario we will have to deal with, which is quite different from this scenario, and both are long gap esophageal atresias. Now, in this situation, ultimately, we have to do esophageal substitution, which is not a bad option at all. And many children benefit with esophageal substitution rather than a very difficult course, ultimately questionable native esophagus. But let us see what the future holds. Now, I'll give you the examples of each type of case. So this is a child with pure esophageal atresia. Gastrostomy has been done, and the parents opted to, this is for pointer, now opted to wait and see if the native esophagus can be built. This is the upper pouch. It's quite a large one, and the door, of course, cannot be seen. Now, we have waited. So this barium study done on 105th day. That means 3 months and more, 3.5 months have been already gone. And this upper pouch is a little big, quite a big pouch. And the lower thing has also grown. I didn't show you the earlier picture, the tiny one that has grown, the stomach has grown, but still the gap is about 4 vertebrae. At that point, we decided to operate. And a thoracotomy was done, right thoracotomy. And then we found the upper esophagus is very dilated and thick, and lower esophagus is still small. We put a dilator into the lower esophagus to make it visible to us in the chest. But still the gap was quite a bit, but the advantage was this was a very thick, sturdy pouch, and we were able to make a flap out of it, the usual gow flap like that, and that would push it down like a tongue of tissue and suture it longitudinally, and then that was able to meet the lower esophagus. So though we waited for 3 months, ultimately we preserved the native esophagus, but with a flap. And this child has done very well. And this is the child after several years, and he's doing very well, and he has no issues at all. But you can see there is some amount of hiatus hernia, which is asymptomatic. So this is a success story of preserving the esophagus in a case of pure esophageal atresia. But having said that, we have tried in the past 2 years, we have tried 3 patients with this technique, but only one we have been able to get the native esophagus together. Other 2 have gone for esophageal substitution. Now, one thing we're always learning, and the word of advice I would give when contemplating exploration of this kind of child is don't do a thoracotomy in the beginning, because it may be an unnecessary thoracotomy and you will not be able to get the ends together. So I think it's much wiser to explore the neck first and deliver the upper pouch. You can mobilize the upper pouch very nicely, and then you lay it over the chest, over the sternum, and see how far away is it from the lower pouch. And it is unrealistic to try and get these 2 together, or can we get it together directly, or can we get it together with a gow flap? Or if it is unrealistic, we go for esophageal replacement. So we must be prepared for all these outcomes, but we have avoided the thoracotomy by doing the neck exploration first. So it's a simple thing, it's a very sensible thing to do. Now, coming on to esophageal substitution, which is necessary in many cases. The 3 classical methods, stomach pull-up. I do it by the retrosternal route, and you can see the stomach lying the retrosternal route. It's quite a big structure. Or an ileocaecal pull-up. You can see the ileocaecal region anastomosed to the stomach. The ileum is anastomosed to the neck, and the cecal end is anastomosed to the stomach. Or a colonic pull-up. So these are the 3 methods which I have used. Of course, like everybody else, stomach pull-up is the one I've done most, and I'm very happy with it. But there are certain problems with that, being a very bulky structure, as not suitable for small, less than 1 year of age. I would definitely wait for more than 1 year of age before doing a stomach pull-up. But we are having a parent-driven need for people who are keeping in the ward and sucking and sucking and sucking and waiting for a primary anastomosis. And then we say we can't do it, they'll be very unhappy. So in those cases, we started doing ileocaecal pull-up. Of course, I have done this operation plenty in other cases in older children for stricture, but it is a very suitable one for a child which is less than 6 months old. They tolerate the procedure very well. I'll come. That's the main thing I'll be speaking on as regards esophageal substitution. Colon pull-up, I've done some, but not my favorite if we can get away with other things, because the colon blood supply is very variable. Sometimes the left colic is good, sometimes the middle colic is good, sometimes the venous drainage is not good, and so on and so forth. Now, just to sell this point of ileocaecal pull-up, this is an only conduit which is having active peristalsis transmitting the food bolus. This is a child which is 15 years follow-up. You can see how the thing peristalsis and takes the food downwards. And also notice that it is of course tortuous, but it is not a bulky structure. So this child is follow-up of 15 years. He came last year. Yeah. Now, how is it done? The ileocaecal segment is pulled up based on the ileo-colic vessels. I omitted drawing the veins. This is an ileo-colic artery, and that should be preserved at all costs. That supplies the cecum as well as the small bowel. Now, the superior mesenteric branches can be divided, and often there is a wide mesenteric gap, which we talked about in another paper where there was a mesenteric hernia in this situation this morning. Wide mesenteric gap which is almost constantly present. But what we must always preserve is the arcade of vessels, like a meshwork of vessels going along the ileum. We may divide a certain branches away from this mesh of vessels if your length is short, but I'd rather not do it, because always there is a very wide mesenteric defect. So having done that, we have adequate amount of small bowel measured over the sternum. This also I bring by the retrosternal route, and that is laid down like that in the retrosternal route, anastomosis to the esophagus, and other end anastomosis to the stomach. And an additional thing, you know, I like doing mitrophanos. The appendix is brought out as an appendicostomy, which is very, very useful for feeding. Peristalsis is intact. Upper anastomosis may be end to end or end to side. Often end to side is more comfortable, and this is cecogastric anastomosis. The ileocecal valve prevents reflux. This is another child showing how it is mobilized. You can see there's the cecum, the appendix, the terminal, long bit of terminal can be kept with the thick mesh of blood vessels here, and the wide mesenteric defect can be utilized to give mobility. There's nothing in it, so it can be cut. But this is very judiciously done. So this is a case we did recently. This is measured. Yeah. No, it's okay. So this is the ileal end, which will go to the neck, and the cecal end will go to the abdomen after putting it through the retroperitoneum. And you can see the leash of vessels which is kept along it. Some are judiciously ligated. Here, again, to emphasize that inspection of the mesentery and its gaps are important. Appendix, that's the cecum, which is being anastomosed to the stomach. The ileum goes up through the retrosternal route. The appendix is being taken out to form a feeding stoma. Many of these children take a little time to feed because never had sham feedings. Same thing, appendix brought out. Now, outcome, the operation can be done even in a this is a 5-month-old baby on whom we have done. Very smooth post-operative recovery. I'm really impressed with the smooth post-operative recovery because the distended stomach is not lying in the chest. There are no respiratory issues, and recent case, we've even electively decided not to ventilate because the previous cases, the ventilation was really not necessary, but as a matter of habit, we are ventilating them. But recent case, we said, okay, we'll not ventilate, and the child didn't turn a hair. Now, additional selling points for the ileocecal pull-up. Number one, 2 ways of neck anastomosis, as I said. One can be direct, but sometimes the small intestine curls up like that. So we can do an end to side also. And this has helped me in one case where many years later, he came with a stricture of the native esophagus here. Anastomosis is okay, but this is a stricture case, here. So I was able to reoperate on him and use this bit of bowel to supplement that. So it has got its own uses. The vagus nerve is not disturbed. In a regular stomach pull-up, that is one problem. It is automatically vagotomized and the stomach becomes very distended. The appendicular feeding port, the ileocecal valve is retained and it prevents reflux. So the danger of aspiration is very low. Of course, this is a dye study showing feeding going into this fecal thing, and it goes down easily but does not reflux. But the additional thing, there is one additional anastomosis between the ileum and the colon. That's the one disadvantage. But the main thing is the ileocecal segment is less bulky. You see the stomach here, and you see this one there. It's much less bulky. And the stomach, of course, I'm not decrying the stomach pull-up. That is my favorite operation. So I'm just talking against myself in that regard. But in this particular case, the stomach is so bulky that there is a lot of space here, and it caused a hiatus hernia. So the child is having respiratory distress several weeks down the line, and what is happening, we did dye study show the hiatus hernia. So these are things don't happen in this sort of thing because the opening is quite small. Now, coming to the next chapter, problem in the failed esophageal atresia and PA. Now we are off the pure atresia group. In the failed esophageal atresia and tracheostomy fistula, same diagram, sick child, bad lungs, bad esophagus, sitting in a bad chest. The esophagus is strictured, may have a secrecant fistula. The lung is collapsed and sitting in a chest has been probably entered number of times. It's a frozen chest. The opposite lung is also multiple attacks of pneumonia. Child is malnourished. So it is a bad situation. So Now we have to somehow bridge the gap that remains if we want to save the child. So we can have a temporizing esophagostomy or a gastrostomy or even a feeding jejunostomy. But when you're planning for the ultimate repair, one problem is there, that what do we do with the remaining sick esophagus? So what do we do with this esophagus? Because sometimes it can be quite restricted in areas, but other areas quite bulky. So what do we do with that? Now, re-thoracotomy to remove that will be very, very traumatic for this sick child. And already this child may have had multiple thoracotomies. So we have some suggestions for avoiding a re-thoracotomy, but yet providing some solution to this remaining esophagus. Now, if the esophagus is not so large, and there may be a residual fistula, which may be a missed fistula, but this kind of case occurs in what is thought to be pure atresia, but actually it's got a small fistula. Then you can leave it cut here and leave it hanging on the thing. It will drain by the tracheobronchial root, and that's the remaining hanging like that. I have done it. It has not caused any problems. And you do whatever method of reconstruction you want to do. The other possibility, when the esophagus is quite bulky, you are a little scared, it doesn't have a fistula or a very tenuous fistula, it will form a cyst if we leave it like that. Then you can have done some sort of Roux-en-Y procedure to drain the esophagus. So the esophagus is drained by Roux-en-Y because the contents don't reflux up. It has peristalsis occurs this way, and this has also worked. And you may say another anastomosis, but this is a much simpler thing to do than another thoracotomy. Some examples of the sick retained esophagus. Say this child had esophageal atresia repaired, and she has got multiple strictures in the esophagus. But in between, the thing is quite dilated, it's quite bulky. So what should we do for this thing? We've bridged the gap somehow. She is very malnourished. Another child, multiple thoracotomy is done, and you can see the chest is like that. And the reason was a recurrent fistula. Recurrent fistula were explored and re-explored some elsewhere once by us, and they've resulted in this sort of situation. Here again, the esophagus is sitting there. What do we do? So in the number one child, multiple strictures, what we did was we did a gastric pull-up, and the lower end of the sick esophagus, we just made a hole in the pylorus and stuck it on there, and she has done very well. And the other child, we did a dye study of the stomach that showed the stomach was quite good and there was no reflux. So we were happy to leave the fistula as it is and just bypass the whole thing by a colonic conduit. So, and she's left with the hanging esophagus with a fistula, but that fistula has been bypassed and there is no reflux, and the child is doing well. So re-thoracotomies have been very disastrous. So these are the two kids which I talked about. One is the multiple strictures, the other is the second physio. We are like Dr. Senthilnathan, we requested them last night to send photographs, and they sent photographs, and that is the outcome. So I've just left you with some thoughts about a long gap esophageal atresia. Thank you.
Thank you, sir. Dr. Saoji, are you there? Dr. Saoji?
Yeah, good evening, everyone. Hello?
Yes, Dr. Saoji, you can carry on.
I'm very much here. Good evening, everyone. Can you hear me?
Yes, we can hear you. Dr. Saoji, we can hear you.
Okay, okay. Thank you very much. Thank you very much. I'm extremely pleased and consider myself honored to be here amongst one of the most vibrant regional chapters of pediatric surgery in India. Thank you very much, Dr. Pavai, Dr. Ramesh Kumar, for inviting such a wonderful program. After previous two speakers, my job is not to focus on various procedures, indications, etc. But I'm going to focus on one of the most worried issue or the daunting task which every one of us, those who are doing esophageal replacement, can easily vouch for it. I'm just trying to open my.
Dr. Saoji, I'll share your slides. Is that okay? Or do you want to share?
No, you can share. No
Yeah.
problem. Just to give you a brief background about why I'm going to talk about this most daunting type of esophageal, periesophageal replacement management, because I am excluding totally here other methods like esophageal lengthening, etc. Because esophageal replacement is going to be required in good number of cases, and we should be familiar with it. And it also depends upon in which part of the geographical situation where you are practicing, where lengthening of the esophagus perhaps may not be possible in most of the places where we all work. So while considering or formatting this Nagpur perioperative or novel perioperative protocol, I just would like to focus your attention to this esophagus, why we are having problems with this type of situations, as the previous speaker told about usage of beta blocker and other conduit, etc. Esophagus is a very peculiar and having a very unique surgical anatomy. That is, it traverses 3 compartments. And when you contemplate for any esophageal replacement, irrespective of the conduit, you very grossly violate 2 major body cavities, that is abdomen and mediastinum or thorax. And this results into a very unparalleled disruption of body homeostasis. And this is extremely different from other so-called supra-major surgeries, as you think of like liver resection or reconstructive urology or major pancreatectomy. These are also of very large magnitude procedures. But esophagus is very unique because you are disturbing very, very crucial homeostasis because of 2 major body cavities are affected. Again, I am just focusing that almost 99% of the cases we would be doing are of benign conditions, which were already highlighted by previous 2 speakers. And then what is important is, from surgeon's perspective point of view, we have to have anesthetist's intraoperative technique and intensivist approach in the ICU to make the difference in the outcome of these cases. And that I'll be discussing in my protocol. But these are the 2 very important issues, and therefore why surgeon has to be a leader as far as this procedure or care is concerned. As I already told, it's very distinct and demanding because of various reasons, mainly physiology. And surprisingly, when I went into the depth of literature, I couldn't notice any well-described protocol in English literature, at least. And leave apart, there is no early recovery. One of the publications which I have sent is for ERS, early recovery after surgery, ERAS protocol. So next one, please. So goals of the care, because most of the problem which we face are as a surgeon, very less problem on operation table, but immediately in the post-operative period, either in the PACU or in the PQ, where the baby would be shifted subsequently. So I would like to extubate baby on the table. And therefore, most of my strategies would be hanging around or would be focusing around on this aspect. And of course, the major daunting task, cardiopulmonary morbidity, which is seen, as the previous speaker told it, they are experiencing after 48 hours. If at all they are seen, I am experiencing it in the first 12 hours. That is the difference which I thought I would like to bring to notice. Minimize surgical complications by planning very carefully and utilizing certain surgical techniques. And if all this goes well, definitely financial burden comes down, and which is extremely important because as a surgeon, when you counsel the family, this becomes a very, very important part, and you have hardly any second chance to do the procedure, and which is neither accepted in our situations. Next one, please. So this is what is the conventional practice or the conventional protocol CP here, which is really very general, broad-based, and it keeps on changing depending upon the centers where they are being practiced. There is no uniformity. But in general, you would see there is no extubation and mandatory ventilatory care is provided. IV fluids, pre-op fasting allowance, usually anesthetists would, as patient is taken on the table and they are preparing for general anesthesia, the fluids will go in full throttle to take care of preoperative fasting. Second important aspect of routine protocol is standard or liberal, that is 5 to 8 ml per kg or 8 to 10 ml per kg per hour, which is extremely injurious as far as my protocol is concerned. And one of the main reasons for post-operative complication is very liberal or standard type of fluid management being used. And of course, regular maintenance fluid and third space losses allowances, which are usually given, that is also creating a problem. So if you look into 3 aspects, that is pre-op or replacement of the fasting allowance, intra-op, and the post-op maintenance plus third space loss, this is the crux of management if you reduce fluid and have a control over rest of the things. Then central line epidural cannula, sedation and analgesia, different type of anesthetics, different setup will have their different policies, and which definitely have problems unless it's a very, very good round the clock intensive care by a very qualified person if it is available. Diuretics are given only if needed. Steroids are only given during the weaning from ventilator period. Stomach decompression is with simple single hold nasogastric tube, and esophagogastric anastomosis most of the people would do in the cervical region, but there are people who would be doing in the mediastinum as well. Single layer and plus minus pyloroplasty. And of course, jejunostomy feeding, which is there as a safety valve to take care for nutrition and post-operative problems, which will usually start on 4th or 5th day. Next one, please. Now, this is my protocol, which I have designed over last more than a decade, and following very carefully, recording it, and getting some very, very good results in the limited resources situation, as well as you have got everything, but there are problems when it is really required. So everywhere it is applicable. Second important thing, in most of the centers which are developed, the cases are handed over to the intensive care team, and the surgeon takes a sort of a back seat. And most of the surgeons are, particularly in the Western world, are not even aware of what is going on about the cases. I have discussed extensively this aspect with several people during several international meets. So these things ultimately in India, when you have to practice, you have to be a leader, and therefore I have designed this type of protocol and convinced to anesthesiologists and intensivists, which were in the initial period, were a major block to sort of continue or initiate this protocol. There are goals for everyone, for the anesthesiologist, for the surgeon, and a post-operative intensive person. Now, coming to the anesthesia, though it's anesthesia topic, I must highlight, because we must discuss this point with the anesthesiologist regarding their goal of plan to extubate on table and urine output minimum 0.5 ml per kg per hour in a healthy child with no heart or kidney problem is sufficient. Generally, they have got a concept that at least 2 ml per kg per hour should come, and therefore more and more fluid is being given. There is no evidence anywhere in the literature that if urine comes 0.5 ml per kg per hour in an otherwise healthy child, you have got a problem of acute renal shutdown. Not a single article which is there, and therefore, if you reduce fluid and if you put your goal here of 0.5 ml, it is good enough. Then you've got a central line, which either a long line from the periphery, or I use femoral line because if suppose leak occurs in the neck, the central line should not get infected. So therefore, I use femoral line in my protocol. Then you come to a very important area where I was talking about all this time about the fluid. There is no pre-operative fasting allowance. There have been again good number of reports that there is no need to supplant pre-operative fasting period. And secondly, particularly when you put your hand, I do posterior mediastinal approach for gastric pull-up most of the time, though I have done some colons and most of other gastric tubes in the initial period. But now last 103 cases I have done gastric pull-up through the posterior mediastinum. So when you dissect in the mediastinum, there is a precipitous fall at times of blood pressure, or you can see arrhythmias there on the monitor. So there is no need to rush in for the fluid. Here there is no reason why we should rush the fluid, because there is no loss of fluid. Here there is due to some reflex or some vagal action, or because of mechanical crowding, because your hand is inside. If you take out, most of the time problem will settle down. If it doesn't, then inotropes starting there on the table would take care. Never you require any bolus. Then again, antibiotics, usually this being a major surgery, people would start with very high antibiotics. There is no need. Unfortunately, ampicillin, gentamicin, metrogyl combination, which is not available these days. Therefore, I use amoxiclav, amikacin, and metrogyl. Or if it is not available, or if there is any issue of allergy or anything, cephalosporin and metrogyl, third generation ceftriaxone, which is most of the time is sufficient unless there is any complication, major complication which occurs. Now, monitoring is again very important. A strict urine output, our usual urine bag doesn't have urometer. So when you are sort of expecting 0.5 ml per kg hour, you need to have every hourly meal to meal urine output there at the head end of the patient. And as a surgeon, one would keep on inquiring about every hourly how much is the urine output. And mind you, in all these cases, I have never noticed decreased urine output with 2 ml per kg per hour of intravenous fluid, as opposed to liberal type of protocol which were used earlier. Second important thing which I carry out is blood gases, electrolytes, and lactate level at the start of the operation, middle, and in the end. If the facilities are not there, maybe somewhere in the middle one can do it and analyze. This, in fact, I have done as a part of a clinical research protocol and done in around 17 or 18 cases, and I have found no change at all with this decreased fluid intake during the procedure, and then subsequently convinced that it may not be necessary all these 3 times. But if the facilities are available, it is always worthwhile doing this. And one X-ray chest before shifting to ICU, because I don't keep chest tubes. If you want to see any pneumothorax, you can immediately react in the PACU or recovery room and put ICD there. Or if you anesthetist would like to have, for some reason or other, to keep baby intubated and shift to the ICU, then position of the chest tube, position of the central venous line, etc., can be very easily checked with X-ray, and that X-ray is very useful. Now, coming to our own we should do walk the talk as a surgeon. So what is there for us as a technique, we must do very carefully. And the most important part of my initial evaluation, before anesthesiologist puts his tube and giving relaxant anesthesia, I do dynamic evaluation of the airway. Large number of associated anomalies which are unearthed and which are likely to create problem, and then we all implicate as a result of cardiac problems, some other issues, stomach occupying the space, etc. But there are a lot of anatomical or structural issues, particularly hypoplastic tracheal rings, presence of laryngotracheoesophageal cleft, presence of second fistula. You will not be surprised to see one of these anomalies quite not so uncommonly as we used to talk about earlier. And then there are, of course, large tracheal pouch in case of primary repair, where a long tracheal pouch or in case a long gap atresia where esophagostomy, gastrostomy is done, abscess or a mass which is there in the retained esophagus, which is compressing there. So there are lots of information which you are going to get, even vascular anomalies which are extremely common, and those pulsations, abnormal pulsations, can give you a very good idea doing the mediastinal dissection. Now, coming to the mediastinal dissection, very steadfastly staying one's own fingers on the vertebral body on the anterior part. You start with gentle dilating of the esophageal hiatus and enter. You glide your fingers on with the pulp side facing on the vertebral column. You glide it, it will nicely keep on gliding till you reach to somewhere T4, T5 level. There is the real area of difficulty most of the time, where you are likely to enter into different plane when you are approaching also from the cervical plane. But with a good patient, diligent, as you don't leave on either side. Another big advantage of this posterior mediastinomy, unlike retrosternal, is that mediastinal pleura remain usually away from the vertebral bodies in the gutter. So you are on the center, on the convexity there, as opposed to in retrosternum where right side pleura will cross to the left side. So chances of opening pleura is extremely common, whereas in the posterior mediastinum, that if you do a very diligent dissection, you can avoid it. So that is about the mediastinal dissection. Then creation of adequate space. That is another very important reason why stomach pull-up usually seen as problematic. The two areas, that is thoracic inlet and the diaphragmatic hiatus, where the compression or the pressure which is likely to occur. So my usual broad sort of on-table analysis is that once you mobilize stomach after taking ligating vessel, I do excise that gastroesophageal junction in the abdominal cavity itself. And then I take my finger and glide, and which takes you to the apex of the stomach. And that is the point where you are going to site your esophagogastric or fundic anastomosis. So once you do that maneuver, you measure the diameter or width of the stomach by putting 1, 2, or 3 fingers. Most of the time it is 2, 2.5 fingers, or 3 finger width of a stomach. So you create your tunnel, esophageal hiatus and esophageal inlet to that level, and you will not have absolutely any problem as a result of which stomach which is there inside. So that is a very important technical point. I don't need to require any nibbling of sternoclavicular joint or excision or like that, but one has to do it very diligently. Therefore, I begin with cervical dissection, because cervical dissection, entry into the posterior mediastinum, I consider as one of the most tough problem. If you do it after doing abdominal part, then by the time you have already exhausted yourself by doing 2.5 hours of job, and then your focus is likely to waver depending upon the complications or the difficulties you experience during the abdominal phase. So I always start with the cervical phase, and that definitely will give you more freshness and more sort of energy to look into it. Then the esophagogastric anastomosis, again it is to be really very important to handle first both esophagus and stomach very minimally. Handle as far as possible only outer layers and avoid holding mucosa. So it should be very well planned, it should be executed. It should be primary, not secondary, to be done after a few weeks. It will be cervical. It should be wide enough by giving an oblique incision on the esophagus and taking out a button on the fundus of the stomach rather than giving only small cut there. And what I do is intersuscepting type or a telescoping type. My idea of doing this is it has minimized my leak to less than 5% in the neck. In fact, in the last several cases, I have even stopped putting my cervical drain also, and I haven't experienced anything. Initial, my leak used to be with the stomach around 20-25%, and with gastric tubes used to be more than 60%. So those were also problems as far as leak in the cervical anastomosis as a cause of stricture there, as a cause of sepsis there, tracking down of that fluid into the mediastinum and subsequent problems. And very important, there are several studies which are showing cardiac problems or arrhythmias or dysregulation most of the time is harbinger of, or leak is the harbinger of those problems. So this early initiation or early leak, which we will not notice until 5 or 6 days, unless it's a very major technological flaw. But most of the time those leaks will be noticed on 5th or 6th day, but by the time cardiac problem will be there. So to minimize that, I am using this intercepting. And the more important thing is that there is Barrett's esophagus, which has been described in the native stump. If I do this intersuscepting type, I am proposing that the reflux will be very minimal. I have got few radios recorded where a nice rosette type of folds by a J maneuver by pediatric gastroscope. I am demonstrating that a well-formed wall which is taking care. And many cases in the post-operative period where I have done biopsy not showing any evidence of Barrett's esophagus. And anastomosis would be interrupted.
Dr. Saoji, sorry, just running short of time. Okay.
Okay.
Huh? Yeah.
Okay.
Sorry. Thank you. Yeah, you continue, please. Please continue.
Okay. It will be a simple 2-layered with inner mattress using either 4-0 Vicryl or PDS. So a nice intersuscepting bulk there, which will be nicely sitting into the gutter if you do nice dissection in the paravertebral space there. Then the fixation of the stomach to the prevertebral fascia, tremendous advantage, prevent the dragging down of anastomosis, traction on the anastomosis, and if by bad luck leak occurs, it will not leak, trickle into the mediastinum. So complications of mediastinitis and all are minimized. I am doing in all cases pyloroplasty, pyloromyotomy, after following the long series of Louis Spitz. According to him, this is responsible for 0% of Barrett's esophagus in their situation. I am not aware of it, but then since I am doing this procedure, I have also started doing this. And of course, there is no gastric distension most of the time because of this maneuver. And feeding jejunostomy as a part of my routine safety valve, I am doing it. And the last point, which is not covered up here, is multi-hole nasogastric tube, so that this tube should not block and air and fluid should constantly decompress stomach, so that there is no compression of the trachea or other mediastinal structures. In the post-operative period, only 50 to 60% of the maintenance fluid. I give hydrocortisone or dexamethasone for first 48 hours, because this is extremely important that those leaky capillaries, the glycocalyx, which is their inner lining of the endothelium, which is responsible for leakiness, and you see the patient plethoric in the next 24-48 hours in the ward, increase weight usually by some 800 grams to 1.2 kg maximum I have seen in my patients. So therefore, to reduce all these things, use of hydrocortisone and dexamethasone to stabilize that glycocalyx. Diuretic, again, such remarkable shifts of fluid will occur. It is unbelievable, and therefore low dose diuretic for 3 days with monitoring of electrolytes, anti-silogogue agent to reduce, because bronchoria will be there as you are dissecting in the mediastinum. So to minimize that, and sedation and analgesia and all absolutely controlled, very minimal as required. Jejunostomy feeding you can really start, because edema is less, interstitial edema, therefore gut starts functioning by the end of 48 hours. And of course, these basic studies again will be doing. Next one, please. The last slide.
Last slide, yeah.
You can see the results. I have studied this pulmonary complication, cardiac mortality, length of the stay in the hospital, that is in the ICU stay, total stay, with ventilatory support, without ventilatory support, anastomotic leak and infection. On all parameters, there is significant improvement. Since the want of time, I cannot go into the depth of it, but I can discuss very well in the discussion period. So there is a significant difference which I have noticed, and therefore I feel this protocol is coming to great use to me. Thank you very much.
Thank you, Dr. Saoji. Thank you. Thank you. Thanks a lot. We'll take the questions at the end. So Dr. Dariusz, do you want to start sharing?
Hello, everybody. Good morning. This is morning in Poland. Thank you very much for your invitation. My pleasure to be together with you. And many thanks to Professor Pavai for inviting me to your such a interesting meeting. So just what I would like to talk to you, this is about long gap esophageal atresia repair. That is with my own technique that we developed at our department. So for me, the definition of long gap esophageal atresia is very strict. This is just type A and type B, so with no distal fistula. So just briefly about this technique, this is a thoracoscopic repair with a suture placed between upper and the lower pouch. So to keep the traction, and we do repeated stages, usually every 3-4 days, just to connect both esophageal ends. So my experience right now with thoracoscopic approach for esophageal atresia, it's more than 200 cases. So as you can see, there were operated in different countries, and there are all types of esophageal atresia. But I will talk only about type A and type B. Altogether, it's 48 cases. So internal traction was used in 43 cases. And this is just my remark. This is what I always say, that cervical esophagostomy should be always avoided, just only for complicated, very complicated cases, because in this way we lost we lose a lot of important part of esophagus. So this is just a short video. One of our first operation, you can see the lower part dissection with the thoracostomy. You can see the distance. So this is just the suture between esophageal ends, and just approximation with a special kind of suture. We put clips just to prevent any leakage, so you can see the distance. So it was the first operation, and at the beginning, we do it every 4 weeks. So after, oh, sorry, just a moment. Okay, I'm back. So after 4 weeks, this is the same case. As you can see, there is a lot of dissection. So we had to use electrosurgery just to dissect. But as you can see right now, both esophageal ends are overlapping each other. So it was possible to make anastomosis. So how long waiting is optimal for long gap? At the beginning, it was we used 4 weeks, but then we had a case that we were waiting only 8 days. So you can see the distance. And this is the same case 8 days later. So of course there's some dissection, but you can see that right now it was possible to connect both esophageal ends. So after just 8 days without any gastrostomy, it was possible to make anastomosis. And another one example. Okay, it works right now. You can see the distance between upper and lower pouch. This is the second stage, 5 days later. And the third stage, another 5 days later, it was possible to connect. So this is the final anastomosis after 10 days. So we change our protocol. And right now, this is what we do. So always we start with preoperative bronchoscopy. So we do surgery when a newborn comes to our department. So usually within the first few days of life. And thoracoscopy with internal traction. If it is not possible to connect, then we do a stage repair. We don't do a primary gastrostomy, and we are using 2 sliding knots. And right now, every 3-5 days, the next thoracoscopy. So this is just the new procedure. A very long suture. You will see at the moment why it is very long. So it is already passed through both esophageal ends. I put the first sliding knot. Then I put clips before approaching. So in this way, I can use a bigger traction because the clip keeps the line, so I have to use another one sliding knot. So there are 2 sliding knots on both arms of the suture, and you can see step by step, I try to approximate both esophageal ends. So this is the operation that is done without any electrosurgery, just only blunt dissection. So we don't use any cautery, any hook, just only dissection with no hemorrhage, you can see. So look, this is just the final position of both esophageal ends. So just about 1.5 centimeter between. So it was just when I started the dissection, you can see, and the final position. And look, this is the same case 5 days later. Oh, sorry, it doesn't work. Okay, just 5 days later. So you can see the dissection. Right now, both esophageal ends overlap each other. So I open it. Just put the nasogastric tube through both esophageal ends, and just a perfect anastomosis. So this case was really perfect without any stenosis, without nothing. So another one example, if you need another one stage, so you can use the same suture for the traction. So you just reopen the knot and just slide down and try to approximate both esophageal ends. And another example, you can see a small, tiny distal pouch here. Look for the vertebra 1, 2, 3, 4, 5, 6, 7 at the upper end. So this is just after the traction. You can see a great tension. And the same case 4 days later with final anastomosis. So it really works. It really works. Just our results, 43 cases, 3 cases unfortunately we lost. 2 cases had real severe complications, so they required cervical fistula and then another kind of operations. So we succeeded with 38 cases using internal traction. In majority of cases and almost all last cases were repaired in 2 stages. Some of them were repaired in 3. And even one required 6 stages, but it was a complicated case because after the first operation, there was a perforation of the upper pouch, so we had to put clips across it. And then to make a final anastomosis. So at the conclusion of my short lecture, the thoracoscopy should be considered in each case. This is what we do at our department, but of course you need experience in neonatal endoscopic surgery, and we need to master and find the optimal technique. But this is my opinion that I would like to, that this is the message to take home. The thoracoscopic approach will change the way we manage the long gap esophageal atresia. I had only 2 cases during the last 10 years that I had to make a substitution or esophageal replacement. Thank you very much for your attention.
Thank you, Dariusz. And on to Dr. Prabhakaran. I don't think we have time for any questions. Am I right? Prabhakaran?